I'm Dr. David Barold, and on this channel we cover ECG basics and how to avoid common diagnostic ECG errors. This is part 2 of a 3-part series where you will learn the following. 1. What is second-degree AV block? 2. What are the types of second-degree AV block? 3. How do you differentiate between Wenckebach second-degree AV block and Mobitz type 2 second-degree AV block? And 4. The significance of 2-to-1 AV block. Atrioventricular or AV blocks are caused by disturbed conduction of the cardiac impulse from the atria to the ventricles. When a cardiac impulse is conducted normally from the atria to the ventricles, a QRS complex follows each P wave in a 1-to-1 relationship. In second-degree AV block, however, there is intermittent failure of a P wave to be conducted to the ventricles. In other words, there are occasional P waves not followed by a QRS complex. These non-conducted P waves can be called blocked P waves. Central to the understanding of second-degree AV block is the behavior of the PR intervals. The PR interval is measured from the onset of the P wave to the onset of the QRS complex. Wenckebach AV block, sometimes referred to as Mobitz type 1 AV block, occurs in sinus rhythm with an occasional single blocked P wave. In Wenckebach AV block, the PR intervals are variable before a single blocked P wave. There must be at least 2 consecutively conducted P waves before the block to make the diagnosis. In other words, you should see at least 3 P waves to 2 QRS complexes. That is 3-to-2 AV block. There may of course be more than 2 conducted P waves before a block of a single P wave, such as a 4-to-3 block. It is crucial to remember that the first conducted beat after the block has the shortest PR interval in a Wenckebach sequence. The traditional form of Wenckebach block consists of progressive and gradual prolongation of the PR intervals, culminating with a single blocked P wave. In traditional Wenckebach block, the second PR interval in the sequence always shows the greatest increase in duration compared to the increase in the duration of the other PR intervals. Let's take a closer look at the PR intervals in traditional Wenckebach block, which are shaded in blue. You can see that they are getting progressively longer before the blocked P wave. Also, the second PR interval has the greatest increase in duration compared to the increase in the other PR intervals. Note that there are at least 2 consecutively conducted P waves before the block, at least 3 Ps to 2 QRSs, and there is shortening of the PR interval of the first conducted beat after the block. Both of these features must be present before a diagnosis of Wenckebach AV block can be considered. However, over 50% of Wenckebach blocks do not conform to the traditional form. The atypical and more common form of Wenckebach block does not have the precise progressive or gradual prolongation of the PR intervals seen in the traditional form. There are unpredictable changes in the PR intervals anywhere within a Wenckebach sequence. Let's take a closer look at the PR intervals. The second PR interval shaded in orange is longer than the first PR interval shaded in blue. But then there is no further increase in the PR intervals until the 5th PR interval shaded in green. Note that there are at least 2 consecutively conducted P waves before the block, at least 3 Ps to 2 QRSs. Also, note shortening of the PR interval of the first conducted beat after the block. Rule of thumb: the diagnosis of all forms of either traditional or atypical Wenckebach blocks can be easily made if the last PR interval before the block is longer than the PR interval of the first conducted beat after the block. In Wenckebach block, if the QRS complexes are narrow, the block is most certainly in the AV node. When the QRS complexes are wide, the block may be either in the AV node or below the AV node in the His-Purkinje system. Like Wenckebach block, Mobitz type 2 block occurs in sinus rhythm and involves an intermittent block of a single P wave. The difference is that all the PR intervals are constant. Constant means all the PR intervals before and after the block P wave are constant. There must be at least 2 consecutively conducted P waves before the block to make the diagnosis. That is 3 Ps to 2 QRSs or 3-to-2 AV block. As you can see, the PR intervals shaded in blue are constant before and after the block P wave. It must be emphasized that the PR interval of the first conducted beat after the block remains unchanged. Very important. The diagnosis of Mobitz type 2 AV block cannot be made in the presence of variable slowing of the sinus rate. The heart rate must be constant. On first glance, this appears to be Mobitz type 2 AV block. The PR intervals are constant before and after the blocked P wave. However, this is not Mobitz type 2 AV block because there is variable slowing of the heart rate. The blue arrows represent the interval between the P waves. The first three intervals are nearly the same, but the fourth is much longer, indicating slowing of the heart rate. Such an ECG can be seen when there is increased vagal tone, which is relatively benign. Do not be tricked into making the diagnosis of Mobitz type 2 AV block by seeing a constant PR interval before and after the blocked P wave if there is ongoing change in the heart rate. Mobitz type 2 block always occurs below the AV node in the His-Purkinje system. It is serious because it can unpredictably progress to block of many P waves, leading to cardiac arrest called asystole. Mobitz type 2 AV block requires treatment with a permanent pacemaker. 2-to-1 AV block consists of alternate blocked P waves. The PR intervals remain constant. It cannot be called Wenckebach or Mobitz type 2 AV block because there is not at least 3-to-2 AV block. The block may be in the AV node or below the AV node in the His-Purkinje system. If you take long rhythm strips, the block may eventually change to either Wenckebach or Mobitz type 2 AV block. Advanced second-degree AV block. This includes 3-to-1, 4-to-1, or higher blocks. There are many more P waves than QRS complexes. In this ECG, there are 3 sequentially blocked P waves so that there is a block ratio of 4-to-1, 4 Ps to 1 QRS. Advanced AV block cannot be classified as Wenckebach or Mobitz type 2 block. Advanced AV block is potentially serious because of the very slow heart rate and also because it is often localized in the His-Purkinje system. The diagnosis of second-degree AV block is an exercise in logic. You will make no mistake if you adhere to strict definitions. That's it. Here are the key takeaways. 1. In second-degree AV block, there is intermittent failure of a P wave to be conducted to the ventricles. 2. To make the diagnosis of Wenckebach or Mobitz type 2 AV block, there must be at least 2 consecutively conducted P waves before the block, 3 Ps and 2 QRSs before the block. 3. In Wenckebach second-degree AV block, the PR intervals are variable before a single block P wave, and over 50% do not conform to the traditional form. 4. With all forms of Wenckebach AV block, the last PR interval before the block is longer than the PR interval of the first conducted beat after the block. 5. In Mobitz 2 second-degree AV block, all of the PR intervals before and after the block P wave are unchanged. 6. The diagnosis of Mobitz type 2 second-degree AV block cannot be made in the presence of variable slowing of the heart rate. And 7. 2-to-1 AV block is neither Wenckebach or Mobitz type 2 AV block. Next, be sure to watch part 3 to complete this series where we will review several ECG practice strips to test your acquired knowledge. Drop a question or comment below and be sure to subscribe and click the bell icon to be notified of my next video release.